Welcome everyone to our latest webinar, Valuing Local Context, Putting What Matters to Communities at the Centre of Health and Care. My name is Emma Hoban. I'm the Manager of the Australian Centre for Value-Based Healthcare at the Australian Healthcare and Hospital Association. I'm joining you today on the lands of the Ngunnawal people, and I pay my respects to the elders past and present and emerging. I would also like to acknowledge and pay the respects on all the various different land, to the traditional owners on all the different lands on which we meet today, and recognise their continuing connection to land, water and culture. So today's webinar will be looking at the valuing local context and what that means in our rural, remote and Aboriginal and Torres Strait Islander communities. Australia is a vast country made up of diverse communities who all have unique experiences and environments that impact their health and well-being. The health and well-being needs of people in Mount Isa, for example, is very different to that of the people in Sydney or Melbourne. Yet the structures within our health systems are not always well equipped to recognise it. We are often working within a system designed to support a one-size-fits-all approach that does not provide the flexibility to enable place-based solutions in response to local need. The Oxford Centre of Evidence-Based Medicine recognises value as a relationship between resources, outcomes and context. To embed value, we must focus on all aspects of this relationship. Today, we are going to hear from a panel of experts who are exploring innovative approaches to the delivery of place-based, context-driven solutions in health and care. Joining us, we have Sandy Gillies, the CEO of Western Queensland Primary Health Network, Greg Sam, the CEO of the Royal Flying Doctor Service, Australia Southeastern Section, and Dr. Alicia Vesey, a proud Torres Strait Islander obstetrician and gynaecologist, and co-chair of the Queensland Aboriginal and Torres Strait Islander Clinical Network. If you have any questions for our panellists throughout the session today, please use the Q&A function at the bottom of your screen, and we will get to them throughout the conversation. So, Sandy, we might start with you. You are the CEO of the Western Queensland Primary Health Network, as mentioned, which covers a total land area of also almost 1 million square kilometres. That's more than half of the total land area of Queensland. It is home to approximately 60,000 people and is of which 10,000 are Aboriginal and Torres Strait Islander people. Can you tell us a little bit about your role, the role of primary health networks in understanding and responding to community needs, and the value of recognising context in the delivery of place-based models of care?
Yeah, look, thank you, Emma. Look, PHN's role is to assess healthcare needs of their communities and then commission health services to meet those needs to minimise gaps and or duplication. We also support at a community level health services to connect with each other to improve people's care and strengthen the primary healthcare system. Some of the probably, you've already raised the difficulties we encounter on the ground covering an area such as nearly 1 million square kilometres, 55% of the state. Small population in comparison to other big areas, 63,000, we could fit them in Suncorp Stadium. Which is what I wanted to do when COVID was around. I just thought we could all went to Brisbane and, get COVID injections or vaccinations in Suncorp. But healthcare access in rural remote communities, especially this vast expanse of Western Queensland, is a primary concern. The region experiences ongoing challenges in the provision of essential primary healthcare or Medicare funded services to the residents, where in our region almost 40% of the population cannot access Medicare. And if it wasn't for Royal Flying Doctor Service, then those communities would not also be able to access a GP. The challenge is obviously compounded by geography, which necessitates residents having to travel significant distances, often at their own great personal cost, to receive basic primary health care and access to pharmaceuticals. The current healthcare models fall short of addressing health equity needs of the population compared with metropolitan counterparts. Our residents here face disadvantages, including reduced life expectancy, higher rates of disease and injury, and limited access to primary healthcare services. And as mentioned, less than 50% of the residents access primary care services. The entire population is classified as very remote, with 80% in areas considered to be the most socio-economically disadvantaged in the state. But we have some hope. Western Queensland PHN, with the support of our partners, have designed a new model of care that we've defined as healthy outback communities. The model shifts the focus from illness to wellness. The healthy outback community model emerges as a beacon of hope. It's directed towards populations that conventional health service models have overlooked. This innovative approach is strategically tailored to meet the unique needs of our residents in rural remote locations. The program is delivered directly to individuals and families where health services have traditionally been scarce or absent. The model is anchored in redefining engagement, navigation, and access. So engaging community and through community and personalised wellbeing plans, which sits nicely with the definition of health from an Aboriginal and Torres Strait Islander perspective. So it's not just merely the presence of disease. It's supported by evidence-based, visibility of local demand and service gaps. The key emphasis in the engagement aspect is that it's on personally in the health and wellbeing space, and that individuals actually personalise their wellbeing journey. As mentioned, it shifts the focus from illness to wellness and places individuals at the heart of the care. Navigation, so we're working closely with the Royal Flying Doctor Service to create a virtual wellbeing hub to provide clinical support and overcome some of those issues around equity and access, and capture patient data and action plans into a single platform. And access, obviously, creating a connected wellbeing workforce to build, embed and coordinate local knowledge and skills in the community. The locally embedded connectors, so they're local people employed in local roles, are going to be instrumental in connecting individuals to community resources. The HOC initiative has catalysed change by creating a HOC alliance for governance. So all the partners sit within our governance model, and we establish, the vital partnerships for a coordinated response to health and wellbeing needs of the community. We've engaged deeply with the regional shire councils in the region, and through that have identified 140 specific local health issues through grassroots community participation. These findings are pivotal for developing and trialling targeted health solutions, which demonstrates a commitment to collaborative design and resource allocation that meets the unique of very remote populations. The next phase of the HOC initiative is going to involve the Commission service providers in those regions and communities in a series of workshops to co-design the individual community and system outcomes we want to measure. That'll demonstrate that healthcare close to home results in improving the efficiency and sustainability of a system. It'll enhance a person's experience with a focus on what matters to them. It optimises the service provider's experience through new ways of working, and focused on serving people across both the health and social care settings, which ultimately will advance health equity by addressing the needs of underserved and high-risk populations through mechanisms such as education awareness, proactive prevention, early detection and intervention, and access to social prescribing, which ultimately will result in maximising population health outcomes through a wellbeing system focused on locally community-driven priorities and data to improve population health outcomes community by community.
Thanks, Sandy. I've just got a question quickly in the chat. Is the 40% people that can't access Medicare because there are limited GPs in the area? Just wanting to clarify, it's not because the people don't, for example, have a Medicare card.
It's because there is no resident GP or pharmacist.
Thanks, Sandy. So Greg, the Royal Flying Doctor Service works with numerous diverse communities across Australia and are often responsible for filling service gaps in areas where there are thin or no markets, as Sandy has highlighted. Can you tell us a little bit about the role of RFDS within the health system, the challenges that you are seeing, and how the RFDS is working with the community to address these challenges?
Thank you. And I'm sure I'm going to cut across a lot of the themes that Sandy and I'm sure Alicia are going to touch upon. But I guess the first thing to say is that from an RFDS perspective, our fundamental purpose was about accessibility, improving access to care, and from a relationship point of view, bridging the gap between a lot of communities and individuals that hold no service relationships. It's fair to say that what is changing rapidly is that accessibility is broadening in terms of, or inaccessibility, I should say, is broadening in terms of not just the very remote and remote communities, but increasingly small towns and small communities that have been sort of let drift from a lot of the hub and spoke satellite restructuring that's going on across health system design. So for us, that's created a need for RFDS to continue to evolve, I guess, our service continuum from the sort of traditional retrieval emergency functions, patient transport functions, but more and more into areas of primary care, pre-hospital care, step-down care, etc. What that's requiring of us, and I make the point that I guess the thinning markets, the failing markets are changing, and there is more diversity. So we have to approach this very much as PHNs and other agencies are, which is to understand community need better, to be able to evolve both our service delivery models and our care models so that they work locally. And I think for RFDS, the other major evolution is that we are becoming more and more integrated within health systems rather than sitting as a sort of failed market gap filler. So we've grown significantly in areas that traditionally we hadn't previously provided a lot of service. What evolved from having resources in communities to optimise the use of available medical and nursing and allied health is now evolving more into the RFDS being a service provider and therefore requiring to be able to have the governance structures, professional and clinical governance around the ability to provide those services. I think the strength for us has always been the relationships that RFDS has been able to hold within community, and that isn't just restricted to those areas that have been recipients of the service. We get a lot of support across the country, across metropolitan areas as well as rural areas. So our ability, I think, to advocate for and shine a light on a lot of the emerging issues in rural, it has also been something we've tried to leverage significantly. In terms of challenges, I guess it's the same challenges that anyone trying to deliver a sustainable quality service are facing. First and foremost, the workforce challenges. We've certainly seen a major shift through and post-COVID in terms of the supply of workforce, the way that training and workforce pathways are able to be directed and supported in rural areas. That has meant, in a positive sense, a need for greater collaboration around workforce, particularly highly skilled and scarce professions. And I think to see ourselves also as a technology-based service, not just because of our transportation platforms or indeed our telemedicine, etc., but also trying to drive the fact that access is being broadened by the lack of technology, by the lack of technological literacy in many communities. It's not just health literacy that's an issue, it's technology literacy. And I think the final challenge we have, again, is the ability to be able to work with so many other different agencies at different levels, to be able to innovate locally, to design locally, and I know we'll spend time on that. And I think in your introduction, you mentioned the fact that there is still this propensity for designing systems for the greatest number. And I think as some of those accessibility gaps that I've mentioned continues to widen rurally, that puts more pressure on how solutions and funding are directed locally, how communities are engaged around both the planning and the design, implementation, and governance and ownership of models. But it is an opportunity that we're seeing in terms of there is, I think, willingness now to at least accept that there does need to be more localised solutions, but that puts more pressure on resources. And ultimately, I think that's going to be the fundamental issue of how to sustain these models of care moving forward.
Thanks, Greg. Alicia, we're acutely aware of the inequitable health outcomes that our First Nations peoples across Australia experience, and the pressing need to do things differently and enable community self-determination. You've done a lot of work exploring approaches to embedding Indigenous self-determination and sovereignty within clinical governance systems. Can you tell us a little bit about that work?
Thanks, Emma. I think before I kind of go into the actual work, I think it's really important to just take a step back and really ensure that everyone understands what I guess self-determination means, and what that and how that relates to the clinical governance standards. So just for the audience, I guess around, we know that clinical governance standards, according to the Commission, is our governance and leadership and culture, our patient safety and quality, our clinical performance effectiveness, the safe environment, and then partnering with consumers. So they're kind of the cornerstones of clinical and governance. And internationally and hopefully growingly within the Australian context, there's been a broader interest and realisation about the role of equity as core to that kind of process of safety, quality and equity. And growing on that again, there's also particularly internationally more of a rise to see an approach of anti-racism within these same frameworks. So equity, obviously, there is, I guess, no quality or safety without equity. And there is no quality or safety in Australia without equity for Aboriginal and Torres Strait Islander people. As a settler colonial state, it's just not possible unless we are always thinking about and centering Aboriginal and Torres Strait Islander people and perspectives. And so when we talk about self-determination, it is not equity. And I think it's really important to ensure that we don't lump all of these things together. So equity, is that individual level of being able to access. It reflects the quality of the system. And we commonly use it as like the closing the gap as a measure of kind of how the system is functioning. But it's also, when we're looking at closing the gap and how we approach that, it's a measure of colonisation and disruption and racism. And when we shift to anti-racism within safety and quality and clinical governance, that's, I guess, more of a proactive, active activity around education and strategic health system reform for anti-racism. But again, it is not self-determination. So self-determination within clinical governance is our communities, Aboriginal and Torres Strait Islander peoples, nations, communities to lead their voice, and they have a leadership within the clinical governance space. And I think that's really important to not equate individual leaders with Aboriginal and Torres Strait Islander leadership, because it's not about individuals being in leadership positions. It's about growing a community capacity of leadership within the system, which means that we have control over our decision making, over the projects, over the solutions, and we have capacity to continue to rebuild and build our nations. And as with self-determination, autonomy, we have the ability to set our own agenda. We have free, prior and informed consent and decision making. We have the ability to build our capacity, and importantly, and you probably heard the word governance a few times today, is governance, and cultural governance comes into that. And so I guess before we talk about the work of embedding self-determination within clinical governance, it's important to understand the two kind of concepts. So when we think about self-determination within clinical governance of our Australian health system, there isn't actually a magic solution. And actually, we've already done a lot of demonstrating as a community and government policies and projects around what is actually required. So the priority reforms for closing the gap actually give us a clear roadmap on what is actually required. to enable self-determination for Aboriginal and Torres Strait Islander people within clinical governance and within our health systems. Those priority reforms, obviously they've got 1, 2, 3, 4. I actually kind of personally think that starting from 4, and that is data and data governance and data sovereignty at a place-based level is key. And that extends beyond the closing the gap key priorities. That is actually data around our patient safety and quality, around accountability and transparency. How do we expect to engage with communities at a place-based level if we do not provide them the data to be able to tell them what they need or want? And so data is key to any kind of ability to ensure communities have self-determination. And that sharing of data is absolutely paramount. As we kind of build up, obviously then priority reform 3 is transforming government organisations. And this is where I guess that more anti-racism approach comes into, and this is the work of the system to transform itself. It needs to partner and engage, but actually at the end of the day, the system and its systems leaders need to drive this work. And so this also then relates to not just at a government high level, but also within our health systems and our patient safety and quality systems. So we need to have transparency and accountability, an anti-racism framework embedded into patient safety and quality, just like every other, like that's happening in the US and in the UK. And we also need to then build in additionally here, cultural safety within these processes. How do patients escalate their concerns of deterioration? Is that a culturally safe way to do it? Then I guess when we think about priority reform 2 and community controlled organisation, I mean, for 50 years, our Aboriginal community controlled organisations have demonstrated the absolute benefit of community owned primary healthcare, as well as at a place-based level. So, I mean, I don't think I need to talk too much about that because I think it's well demonstrated about the evidence of community controlled. But I think that is a key component of broader systems response. But within clinical governance, I think it's important to share how we approach our relationship with community controlled, their ability to access activity-based funding, to recognise the work that they're doing, to not just shift responsibility without funding and support mechanisms, innovative workforce solutions. There's many ways that we could approach that. And then it comes to the final priority reform number 1, and the shared decision-making at a place-based level with community, with governance embedded. And I think that this is key around what I touched on before, is that it isn't about individual leadership, Aboriginal and Torres Strait Islander people in leadership positions. What is actually required is formal partnerships that have cultural governance at the heart. And so when I guess then talk about what we are actually doing at, I guess in Queensland with the Aboriginal and Torres Strait Islander Clinical Network is around trying to slowly embed some of these things in a very practical operational manner. So as the Queensland Aboriginal and Torres Strait Islander Clinical Network is about 2.5 years old, we established towards the end of 2021. And I think that was an important step in realising the leadership of Aboriginal and Torres Strait Islander clinicians and that ability for us to engage with community controlled, with the Office of First Nations Health, which is our policy and strategic arm of Queensland Health, as well as our local Aboriginal and Torres Strait Islander leadership within each hospital and health service. And this network has then been able to build a community, a collective, and we've been able to start setting, I guess, the agenda. And I think one of the challenges is that for Aboriginal and Torres Strait Islander people within the system is that the agenda is always set for you. You are told what you need to focus on. You are told what projects you can do. You're told what funding you can have, what data you're allowed to access. And it has been really I'm going to be honest, it has actually been really difficult to resist that urge to meet all of those requests from external and to keep the network focused on the strategic work of asserting our own self-determination within the system and setting our own agenda. And very early on within the establishment of the clinical network, and I must acknowledge that Dr. Mark Wenatong as the inaugural co-chair alongside me 2.5 years ago, We identified that we needed our own Aboriginal and Torres Strait Islander people within the system, and eventually externally, needed access to data. We needed to understand what was happening in the adverse events that are happening to our community within our health system. And so really concentrated on advocating and for access to that through a quality assurance committee. And we hope that we will see that realised in the short future. And that quality assurance committee will allow us to not only access to data, but to tell our stories, to narrative, and to start to examine our health system for harm from racism, from cultural, unsafe care. We also identified, the escalation of concerns and the cultural safety around patients that require to escalate if they're deteriorating. And then we've also been working with, the systems performance branch around the indicators and measures and how do we create accountability of equity within the system. Yeah, that's some of the work we've been doing. We've got a broad agenda, but I think the difficulty is that the Queensland Aboriginal and Torres Strait Islander Clinical Network is an amazing body of Indigenous leaders and allies, but as with a lot of things, the ability to really demonstrate and enforce our self-determination is still not quite realised because we are limited by skills, capacity, and I guess not skills, but enough people, I guess, and the time and the funding. And that still all relies on external bodies and external mechanisms, which according to the priority reforms shouldn't, because government has already committed to this. And so it can be frustrating to have to continually submit a case for this work when it actually is already committed to by all the governments. So it's an ongoing process, but we hope that with time we will continue to slowly shift the system.
Thanks so much, Alicia. That sounds like some incredible work that you guys are doing there. I might just pick up on your point about the importance of data and ask a bit more of a broad question. We talk about using data to drive improvements in healthcare. However, when it comes to understanding what matters to rural, remote and Aboriginal and Torres Strait Islander communities, are we currently measuring the right things? I might start with you, Alicia.
I thought I was going to get a break. Look, I think data comes down to the old co-design, and I don't think we do co-design well. Are we collecting the right mechanisms? No. We are collecting it for self-determination, for place-based decision-making and governance. I don't think so. I think that the move towards value-based healthcare and a focus on patient-reported experiences and outcomes and is a step in the right direction. And I think that we can really leverage that to enable more of a local-based way of approaching data. Yeah, and I think that the translation of how that data is, a narrative around the data and how it is framed, creates such a big impact on then the models of care and how they're decided and who gets funding and the approaches. And I feel that co-design kind of comes in at that later point when actually community involvement, consumer base should have been involved from the very beginning of deciding what data so that we can then enable down how the model of care or what even should be the approach. But I think that comes down to the simple mechanisms of Indigenous data governance and sovereignty, where it's not just about access to data, but it's also about determining what is important and who gets to decide. That is probably a key.
What about you, Sandy? Do you think we are currently measuring the right things?
I fully support what Dr. Veazey has said, and I think the emphasis on outputs is, obviously the way that all the mechanics of policy and funding levers, and those metrics are the same for everybody regardless of postcode. And I suppose that's what we're pretty excited about in relation to the HOC initiative is that we're moving towards value-based healthcare outcomes that are determined. And as I mentioned in my opening, was that those metrics or those outcomes will be co-designed with community and commission service providers that we are going to fund. So we're funding what matters to them as opposed to what matters to somebody to populate a dashboard that says that, you know, whilst we didn't meet a 5% increase in mental health services in rural remote Western Queensland, proportionally to population 100,000, we're number one in Australia. So I think data for the sake of data presents a very different story. And we definitely, very similar to Aboriginal Community Control, are calling for our ability to participate in what those metrics are and measure what matters to us as opposed to what meets some sort of government or bureaucratic process.
Thanks, Sandy. Greg, did you have any thoughts on data and what we're measuring currently in healthcare?
I think to support what's been said, the issue of what has value and to whom is something that is ill-defined and is variable across the country in terms of how that is determined. And a lot of, particularly accountability and reporting frames, are set, as has been said, universally. So the concept of what represents a quality outcome and value for money is relative to what is determined as what is the quality and the value, and that's often predetermined. That, to some degree, is a perverse disincentive to innovate. So you tend to follow what you have to do to fundamentally enable access to a lot of either those fundings or the way that models are prescribed. So I think that issue of enabling localised or at least regionalised or cooperative senses of what value is applied to data and where is it directed, what's its utility, and then how it's governed is the single biggest problem we have at the moment.
Thanks, Greg. So you all kind of mentioned or alluded to the idea of co-design. When co-design is done right, it enables a wide range of people to contribute to and feel ownership over the formation of a solution to a problem. Can you reflect on your experiences of co-design in your community? Sandy.
Look, co-design done right is it has a really strong requirement for partnerships between stakeholders and a willingness to change. And I heard a good quote last week: systems don't change systems, leaders change systems. And I think when you've got the exact right leaders in play, it's almost like the universes have aligned. And as an Aboriginal woman myself, it's usually a sign from the ancestors that we're ready to go. But you know, I think the HOC initiative, for example, was pie in the sky, but we've got exactly the right leadership in play. We've got community people that that want change. You know, Greg just talked about it. You have fragmented policy and funding that comes down, and we've got to retrospectively fit what is required from those deliverables in order to get the funding to do the job. So whereas co-design and you know, collectively, you know, we're greater as one, a unified voice, I think is paramount. And that, you know, what doesn't work is that idea of one size fits all. So even between, you know, the HOC communities as an example, got 3 different shires with 3 different community dynamics, you know. So how engaged local government is, or how engaged the local TOs are, and where they see their place, and even if they're part of the solution. So I think it's place by place, and Sean Rooney in the chat's got something around place-based co-design approaches to service planning. Requires key skills and approaches. How do you ensure these processes are inclusive? And I think it's community by community. Which means there's got to be a lot of emphasis on engagement, and not just for the sake of ticking a box, but the thing that we've got around the issues register, they're community issues, and we've taken them, we've put them in a register and fact checked them against them, and we will then together solve together for a solution.
Thanks, Sandy. Alicia.
I think it's, you can't come in and just think, I'm going to co-design. Like, I'm going to do this in a co-design way with any project or plan. And I think it actually takes a movement and a strategic building of capacity of the community and of yourselves and of the organizations that you work within and that you're working with. And I think that the excuse can be that it's too hard, or that health literacy, or they don't understand the system, and that can come into play with co-design. But I think that with the right leadership and governance, and Sandy's kind of touched on it, when you've got this the stars have aligned and the right leadership in the right place at the right time, then you can progress large pieces of work like Sandy and the Southwest region have to do that. But you've got to create a social movement. You can't just it can't be an individual. An individual can, and a leader can kind of create the leadership capacity, but you can't just do it individually. You have to build a collective around to actually build co-design capability.
Thanks, Alicia. Greg, did you have any reflections?
Well, perhaps just to reinforce that the concept of delivering care and I guess the resourcing to support that is the relatively easy bit. That in our experience, it's a lot of what has worked, and not all communities welcome or necessarily want a particular type of service. So the engagement with the community, as has been said, and the relationships with the community, and understanding the community's readiness to go and work with a number of either providers or agencies, or indeed just govern what goes on, requires a lot of work that at times sits outside of sort of traditional service planning and service funding. So it is very much around maintaining a relationship over time and building a sense of trust and responsibility with communities to read it correctly. So when you actually sit down to think about co-design or service availability, those factors are already there. You're not starting from scratch. And I think what we've seen, particularly with the decline in a lot of sort of East Coast rural communities, the decline of the sort of small community general practice, hospital, and even multi-purpose centre sort of functions, and the for-purpose organisations sort of fitting around that now there is an opportunity where that declines for other agencies to actually establish that primary relationship with communities around what are healthcare needs, but not only that, but what are the supporting factors that will enable that to occur and importantly sustain. We have surveyed and engaged a lot around what communities want, and the variability is enormous. And our ability as a single service to meet that is clearly limited. So therefore, again, it requires us as a service provider to understand what the service availability is, accessibility is, and indeed what communities see as having value, as we spoke about before. So, co-design sounds easy, but I think it's been said, it fundamentally requires a degree of pre-existing trust, relationship and confidence that at the end of it, what you're going to get is a service that is both sustainable but accepted, and then issues of quality and outcomes will come. And those factors are very hard at times to measure and quantify in funding submissions. So organisations like ourselves that do have some sort of charitable capacity to be able to self-direct resource so that we can spend greater time on community engagement, has shown that that's where our greatest success in community co-design has come from.
Thanks, Greg. So we have some fantastic questions coming through the chat. Got one here from Rose. I'm wondering where aged care fits into the puzzle. Aging in place, healthy aging, taking a similar approach to wellness rather than illness. Sandy, I might throw to you on this one.
So yeah, Rose, what I probably didn't, and I've just asked my guys to make sure they've uploaded all of the HOC collateral on our website, which you can go and have a look at. But the HOC model has actually been designed across life stages as opposed to disease focus. And so ensuring that we're taking that wellness preventative approach across each of the life stages. And look, I live in Winton, so I live in the bush, and my parents live in Charleville. So, and I know that through my own personal experience that, you know, we do a dementia assessment at 72 years of age and we're shocked because family notices differences 5 years beforehand. But no one actually, even from a health system perspective, actually thought to maybe do some sort of preventative screening. So hence why those life experiences have also come into the HOC model. So life stages and aging sits nicely in that from a healthy aging perspective, in the sense that we're actually planning at 50 for potential trajectory and demand on services by 74, 75.
Thanks, Sandy. Greg or Alicia, did you have anything you wanted to add to that?
Not from my perspective, thank you.
I think nothing. I mean, aged care is not really my clinical area, but I think that it's important that a lot of these things requires a massive cultural shift within the health system and the way that we function, and that's not going to be overnight. But aged care, the way that it's a financial commodity, and so particularly within our rural remote settings and particularly within Aboriginal and Torres Strait Islander communities, and so placing again that self-determination and ability to self-govern within communities as a community controlled, you know, sector rather than as a for-profit sector is probably crucial. But yeah, besides a big cultural shift on how we approach that, yeah, not really my area, sorry.
No problem. Another question that we've got come through the chat: would there be value in co-designing national data sets for patient-reported measures that can be used across different care settings and populations of focus? What steps can we do now to progress this important work? Did anyone have any thoughts on that?
Well, I think there are, aren't there? There are some national PREMs and PROMs that have been created. But I think there's, for example, in the mental health space, we use, you know, certain tools to measure PROMs, e.g. K5, K10. We've got the PROM 10 from an allied health perspective. But I think there's an opportunity for us to start actually designing our own patient-reported experience measures in a remote and very remote setting. They're different, just from our early work, that they are different. And I think it's the stuff we've talked about right at the front here is how people consume services and their experience with those services. We often hear it in remote and very remote, you know, we're here to help. Oh, don't worry about us, we're okay. Even they might be fly blown, they've got 3 or 4 chronic conditions, but old mate down the road's worse than me. And so it's how people view their own health and wellbeing, and that's what I think is going to be exciting as a result of some of the work we're going to do with HOC.
Did anyone else want to provide any comment on that question?
I think, yeah, I mean, we know that there's going to be, there's national work, I mean, pockets of work being done around this. I think the difficulty is that kind of at that national perspective is that the marginalized voices get pushed to the side, right? So it's finding that balance between a group effort, but allowing the flexibility of a place-based, regional or culturally specific approach. I think one of the limitations with the current PREMs as they are is that from an Aboriginal and Torres Strait Islander perspective, people seem to only want to measure the spiritual or cultural, I can't remember the exact wording of the question, but there's one that's about your spiritual experience. When actually, when you look at the publicly facing PREM data that's available for some states, Aboriginal and Torres Strait Islander people are offered pain relief less, they feel less heard. So actually the value in the PREM data that we already do have is not actually in the culture specific, but actually in the experience and the discrepancy and equity in the experience of marginalized communities within our health system. So yeah, I think it's important to adapt, but also I think that a national kind of basic fundamentals is going to be important. And I think with the outcome measurements and a shift towards funding outcome measurements that need to co-design, because that's really, I guess, the start, some of that work around funding outcome measurements. Co-design needs to be from the beginning. And I think I can already see the train leaving the station with consumers and community not involved in that process from the very beginning, but being brought in later. And already that's just redoing the same thing that we've been doing for the last 50 years. So it's really, we're in a really interesting, crucial point where we can make a decisive decision to do things differently. But it's going to be a concerted effort of everyone within the system to be thinking of that. Yeah.
Thanks, Alicia. Greg.
Look, there is, I think, a lot of good examples and methodology out there, and perhaps the issue is how to find it rather than does it exist. But I guess to the other panelists' points, the problem with most innovative grants and funding to either trial or pilot at times is disconnected from the ability to convert that and implement it and sustain it and then change the metrics over time. And so the co-design is not just simply about how to start, it really should be how to sustain and how to adapt over time. And that is something that most systems can't adapt to. It relates to just funding cycles, whether that's Commonwealth or state. But I would say that certainly we've found PHNs useful in that regard in terms of being a clearinghouse for understanding where there are good examples of methodology. And I think increasingly, as a lot of the major reviews that are being conducted at the Commonwealth level currently come out, there's no doubt that this whole idea of supporting localised co-design, innovation and models of care is going to need some broader national structure. But to me, the conversation needs to move beyond just design. It really is about implementation and maintenance and governance of it, and getting the metrics right around that, rather than pilots being implemented and showing some early signs of promise and then failing to be able to be converted. That has been the bigger problem for us.
Thanks, Greg. One of the common issues that we hear from health services, particularly in rural remote locations, is the difficulty of adhering to the varying accountability mechanisms of the many different funding sources necessary to develop a sustainable business model in these locations. For example, NDIS, aged care, state, federal funding. Yet accountability mechanisms are also a critical part of maintaining a safe, quality and equitable health system. how, as a system, do we more effectively embed flexibility while at the same time ensuring accountability? Sandy, I know this is an issue that comes through in your patch all of the time. Did you have any thoughts?
Look, you know, we're arguing at the moment for, you know, for a voice from a rural remote perspective in relation to developing policy, but that allows us to potentially just, you know, pool the funding, because at the end of the day, everyone gets the funding for the same population and we're all trying to get the same outcome. But as you've just alluded to, we've all got different metrics to report against, which is fragmented, leading to fragmented care. And so, you know, I think the ability to be able to, once again, come as a unified voice for, you know, I've even asked for another M location being an 8 for very remote, might be a game changer. But, you know, we know what we need to do. Let us get on and do the job, and let us pool the funding instead of compete, because through the very nature of the processes, those that are actually required to work together actually often are competing for the same dollars to deliver the services. Whereas if we actually pool the funding and be as bold as even in those areas where I talked about before, where people are not accessing MBS because there is no general practice. RFDS is the only GP provider in that area, and they cannot claim Medicare in those sites. Let's cash out the Medicare. Let's cash out the Medicare, put it in a pot, pool the other funding that everyone else has, and we might actually start to get some real outcomes for individuals who choose to live in these postcodes. Sorry, I don't know if I answered your question, but yes, I am very passionate about this, and slowly but slowly, I think we're being heard.
No, absolutely, you answered the question. Alicia, did you have any thoughts from a governance perspective?
Yes, I mean, what is the purpose of the accountability? It's, you know, it's to ensure that the money is spent wisely for the community, right? And so I just don't think these institutions should be judging the purpose and the use. And I feel that at a place-based level, local-based accountability would be more daunting than government. Imagine walking down the local store and running into someone who said, I saw that you didn't spend that money how you said you would. Like, that's probably more of a better accountability mechanism, and more effective, and allows for more transparency at a local based service. And I think if the local community had a voice into place-based accountability around how we fund, and, you know, like from a cash pot or however that works, they would then buy into this model, which, you know, of actually having ownership over the system. They would want to be at the table. They would want, you know, you would build that engagement in that co-design process, and start to build this kind of consumer ownership run health system. You know, funding and the way that we fund the health system is key to shifting where the power is. And if the community feel that they have power because they have a voice, or at least have an oversight of where funding is, then it changes the dynamic and the relationship of what's actually valued.
Absolutely. Greg, did you have anything you wanted to add?
Well, we're a highly regulated service across a number of domains: aviation, health, charity, and I think it's fair to say that the regulatory reach, in a very practical sense, is both a barrier and a risk to the delivery of care, notwithstanding the fact that consumers and those who receive care and communities generally should expect levels of safety and quality, and demonstrable levels of safety and quality. And often it's left to services to walk that line and to some degree manage trade-offs, when in actual fact, a lot of those quality assurance initiatives are not funded. And the degree of difficulty with which to implement it and then measure it and then assure it and report against it is significantly higher than if you are within a service reach in a secondary or a tertiary level service reach. And I often give the example of one part of our service having to meet the National Quality Safety Standards on infection control because we were providing some outreach services in a shearing shed, and it caused about 6 months worth of consternation about how are we going to actually define what is the standard. And at the end of the day, I think it belittles the fact that the available resources we have to provide care in very, at times, different healthcare settings and care settings does require, again, a local solution that meets a degree of assurance between community expectations, professional standards, and I guess the agreed relationship between the provider and the recipient of that care, particularly, as has been said before, the limitations of the Medicare system and the Medicare support ecosystem to support and enable quality general practice is fine, except that model, certainly in our service area, is not the predominant way that primary care and general practice is delivered. And we hope that through the reviews that are going on currently, that actually is now more structurally recognised. And it is also a limitation, I think, for the attraction of workforce to come and work, because there is a sense of a quality divide, potentially, if there isn't a system that actually enables locally to assure that you can operate at the top of the scope of your practice and your service is both recognised and demonstrably seen as high quality and enabling you to operate at the top of your practice. So it's that sort of red tape overreach of regulation that's universal that requires a significant rethink, the more rural and the more localised you want to get.
Thanks, Greg. So we're coming to our end of our time today, but before we go, I just wanted to ask each of you, if you had one wish for the health system in the next 3 to 5 years, what would it be? Sandy.
I was going to follow the lead of the others. Look, my one wish is it'd be lovely to, and I think we've got some hope with the new National Health Reform Agreement midterm review, is actually focusing on the health system and allowing us to get on and do the job based on, on our various roles. But a real emphasis to look at health across the continuum of care, as opposed to which system is the most important part of the system, e.g., whether it's a public health system, but let's actually join up primary, secondary, tertiary, because you know what? Consumer doesn't care whose badge is on your shirt. They just want a service. There you go.
Thanks, Sandy. Alicia.
My wishes is probably not that original. I've been old as old as the stars. But I think similar to Sandy, I'm hopeful and have wishes around the midterm review helping. Is that I just want to see the National Health and Hospital Reform Commission from 2009 recommendation. That was the first one that they mentioned in the executive summary, which was for the need for a Aboriginal and Torres Strait Islander Health Authority, and that needs to be at the national, state, and then also at a place-based level. And again, like Sandy said, is not about primary health or secondary or tertiary care, but actually a cross kind of intersected ability for Aboriginal and Torres Strait Islander people to have a voice into the health system and to demonstrate the strength and ability of the way that we actually provide healthcare and health systems as well. So yeah, it's already been around and in the legislation and in the recommendations for the last 15 years. So I'd just like to see that honoured, actually.
Thanks, Alicia. Hopefully that happens. Greg?
Look, same in terms of the major reforms, that there is an opportunity, and I guess some intergovernmental clarity around responsibility for the primary care component to enable a lot of that holistic view to occur, because that's where the gaps open up, where Medicare runs out and state government responsibility at times is not clear. But I think if my wish would largely be, given the state of workforce across the board at the moment, and the fact that rural is certainly now competing across the country for skills, that there is an absolute priority to increase the availability of workforce to rural. And having been very much part of that journey that started 10 years ago and has not seen it's seen some patchy solutions, but there is still a huge issue with it, because it's driving cost, it's driving, I think, and limiting the ability to innovate, and to some degree it restricts the ability to have a community-based and values-based model if the supply of workforce just isn't there.
Thanks, Greg. So that brings us to the end of our webinar today, valuing local context, putting what matters to communities at the centre of health and care. I would like to say a very big thank you to our panellists for sharing their thoughts and the work that they're doing, which is really interesting and fantastic to hear. We here at the Australian Centre for Value-Based Healthcare, we host regular webinars on topics related to value-based healthcare. To find out more, you can see the links on our screen. You can subscribe to receive our monthly newsletter and join the Australian Centre for Value-Based Healthcare LinkedIn community, where we have continuing a lot of these conversations. Thank you again for joining us, and we look forward to seeing you at one of our upcoming events soon.
Thanks, Emma.
Thank you, Emma.